Here is a story about Sue. When playing tennis with her family, she bent down to pick up a ball and snap. She ruptured her Achilles tendon. It was 1 month until she got surgery, 3 months until she could return to work, and 5 months later, snap. She ruptured it again. Sue required open surgery in order to repair her Achilles. This involves making a long incision down the back of the calf and suturing the two ends of the tendon back together. This damages the blood supply and a lot of healthy tissue. The result of this is it was a long time before a patient can begin rehab, leading to an inelastic repaired tendon, which is prone to re-rupture. We are changing how this is done using an anchor-based system. This involves a deployment device, 2 small anchors, and a connecting material. The deployment device inserts an anchor above and below the tear. The anchors are designed to grip within the tendon, allowing the connecting material to draw the 2 anchors close together. This leaves blood supply intact and allows the patient to begin rehab far sooner, leading to a stronger, more elastic repaired tendon. The patient can also benefit from minimal cosmetic scarring, a shorter procedure which can be performed in an outpatient environment, a lower chance of wound complications. We are currently performing tensile testing with the anchors in the lab, and moving forwards are looking to raise £350,000 so we can finish the development of the deployment device and complete preclinical testing. Thank you very much for taking the time to listen today. I'm Grant. Yeah.
Well, I'm sure you're ready for some questions, eh?
Yeah.
So how many procedures in the UK currently that you'd be looking to replace? What is the average cost of those procedures? And you pointed out there may be some.
I don't actually know the numbers in the UK. I know the numbers in Europe. I think the numbers in the UK is 17,000, but I think in the whole of Europe it's about 80,000. About 17,000 might be right.
And the cost?
The cost is around €5,000 per patient.
The cost of surgeon.
Yeah.
And nasty injuries, obviously. And in terms of sort of emerging competitions such as tissue engineering, how do you stack up against these other competitive techniques?
Well, currently, there's kind of 4 main routes of treatment. You've got conservative treatment, which is doing nothing. You reduce the risk of kind of wound complications, infections, all of that. But the repair, if you want to return to sport or something like that, is quite suboptimal. And then you've kind of got the 3 others. You've got a percutaneous repair, which is kind of similar to ours, but the current anchors that they use have to be removed and are also far bigger. They're 9 millimeters wide compared to 3 millimeters wide. So they're not very favoured for, especially within the UK and the US. And then you've got kind of open surgery, as I mentioned earlier, or you've got this kind of jig-like thing. It's called a Pars Achilles repair jig, where it kind of basically facilitates a smaller incision, 4 centimeters long. But it can like kind of assist the surgeon applying sutures. That is kind of where we're at currently. There's a few things on the market which are like less suture material but stronger sutures, but I've not seen anything to do with tissue engineering. So I'd say we're kind of up there with innovating in this sort of area.
Yeah, so two other related questions. Other tissues, so ligaments, and things like cruciate ligament, commonly broken. A lot of.
So you can have applications for other tendons. It's really down to size. We're targeting the Achilles because it's the largest, and also
so that's the easiest place to go.
It's the easiest place to go.
It's going to be anything around hand, for instance.
So tendons in the hand, I suspect, would be too small to work with. So we'd be looking at big tendons.
And in terms of the cost of your procedure, could you sort of comment on that versus current procedures?
The cost would be far lower because you wouldn't have to have a surgeon doing it. To do it in an outpatient facility, all you'd need is an ultrasound machine and someone who's been trained in the procedure. So you could even have someone like a physician's associate performing this procedure. It'd be that simple. So it'd be far lower. That's really as far as I go with costing it, and it'd be very cheap to manufacture.
Thanks for the questions. Thanks again, Grant, for your talk.